everyone. I'm Rosemary, your patient liaison here at the Kidney Cancer Association. And we're closing out our first annual virtual patient symposium with a presentation on side effect management. Our next speaker is a registered nurse at Memorial Sloan Kettering Cancer Center in New York City, and also a valued member of our clinical advisory board. Please help me welcome Karen Kehoe.
Hi, everyone. My name is Karen Kehoe, and I am an office practice clinical nurse at Memorial Sloan Kettering Cancer Center in New York. I have been working alongside Dr. Chung-Han Lee for the past 3 years, providing care to kidney cancer patients. Through my experiences, I have come to understand the most common side effects associated with immunotherapy and targeted therapies. In this presentation, we will discuss how to best manage these side effects in a safe manner. It is important to remember that your relationship with your oncologist should be one of open communication. Never hesitate to call your oncology team to discuss any questions or concerns you may have regarding side effects. Our goal is to get you through treatment and have a good quality of life. I have no disclosures. Our immune system is an auto-regulatory system that protects and defends our body from anything foreign. Foreign can be bacteria, viruses, and cancer cells. When something foreign enters your body, your immune system creates a large inflammatory response where certain cells called white blood cells surround the foreign matter and attack it. Your immune system, being very resourceful, remembers this foreign material, which is also called an antigen, and develops antibodies to prevent or lessen the degree of any future attacks. Sometimes, however, there is a disconnect in the immune system, and we end up with these antigens finding an escape route. We know that cancer cells progress due to an inadequate immune response. They bypass our immune system surveillance and activate certain immune checkpoint pathways, thus escaping immune detection. What immune checkpoint inhibitors do is target and block these checkpoint pathways, thereby recharging our immune system and its response to cancer cells. There are 3 immune checkpoints that are blocked. The first is CTLA-4, also known as cytotoxic T lymphocyte antigen-4. The immunotherapy ipilimumab, or Yervoy, is an antibody that helps block this checkpoint like an antibody that blocks off an antigen. The second checkpoint blocked is PD-1. PD-1 stands for Programmed Cell Death Protein 1. Pembrolizumab, or Keytruda, and nivolumab, or Opdivo, are PD-1 immunotherapies. PD-L1 is another checkpoint that is blocked. PD-L1 stands for Programmed Cell Death Protein 1 on Ligand 1. This is an extension of PD checkpoints discussed previously and includes immunotherapies such as atezolizumab, or Tecentriq, and avelumab, or Bavencio. Now that we have a basic background of how both the immune system and immune checkpoint inhibitors work, let's talk about the side effects. We define side effects specifically as adverse events. By recharging our immune system, immune checkpoint inhibitors can also activate what we call our autoreactive T cells. Creating this autoimmune response can cause any organ of your body to become inflamed. Looking at this picture, it is important to understand that this inflammatory response can really occur anywhere in the body. For example, you can develop an inflammation in your colon, known as enterocolitis. You can develop inflammation in your lungs, known as pneumonitis. You can even develop inflammation in your eyes, called uveitis. Remember, anything ending in the word itis means inflammation. The most common organs in the body that become inflamed are the colon, liver, lungs, skin, kidneys, and thyroid. Uncommon organs to be affected by immunotherapy are your heart, the nervous system, and your eyes. In general, adverse events occur in about 90% of patients being treated with CTLA-4 immunotherapy and about 70% with PD-1, PD-L1 immunotherapy. What we must remember is that even though these numbers are high, many of these symptoms are usually mild. The onset of adverse events is variable. Some patients may experience adverse events after the first cycle, others experience adverse events in the fourth or fifth cycle. The onset of adverse events usually occurs 3 to 6 months from the initiation of immunotherapy. A combination of CTLA-4 and PD-1 immunotherapy stimulates more immune-related adverse events than single-agent PD-1, PD-L1 immunotherapy. One research article identified that 55 to 60% of adverse events occur in combination immunotherapy compared to 10 to 20% on single-agent immunotherapy. Ipilimumab and nivolumab are an example of a combination therapy. Lastly, it is important to remember that patients can get delayed onset of immune-related adverse events for up to 1 year with PD-1, PD-L1 immunotherapies, even after treatment is discontinued. The common terminology criteria for adverse events, or the CTCAE, allows oncologists to determine the severity of your adverse event and treat it accordingly. Each grade has certain criteria that must be met. Grade 1 and Grade 2 adverse events are considered mild to moderate, treatable with early intervention. In Grade 2, instrumental ADLs, or activities of daily living, are affected, such as preparing meals, shopping, doing housework, or handling finances. Grade 3 and Grade 4 adverse events require hospitalization. Self-care ADLs, such as bathing, dressing, and toileting, are affected. In general, we would hold treatment with Grade 2 or higher adverse events. What we really want is to identify an adverse event in its early stages so that we can prevent Grade 3 or 4 and, of course, Grade 5 adverse events from occurring. It is important to call your oncology team at the onset of any adverse event. In doing so, we can manage and treat your symptoms effectively and efficiently. Colitis is an inflammation of your colon that can present as diarrhea, abdominal pain or cramping, as well as mucus or blood in the stool. The onset of colitis for CTLA-4 immunotherapy is approximately 7 weeks from start of treatment. Our CTLA-4 immunotherapy is ipilimumab. PD-1, PD-L1 onset is usually 6 to 18 weeks from start of treatment. Specifically, the onset of colitis from nivolumab is usually 6 weeks, and the onset of colitis from pembrolizumab is 18 weeks. Atezolizumab has a prevalence of 19.7% in developing colitis. Combination immunotherapy, ipilimumab and nivolumab have a 26% prevalence of developing colitis. Depending on the grade of colitis, we may continue to monitor symptoms with diet adjustments, such as a brat diet, which consists of bread, rice, apples, and toast. Sometimes we prescribe an antacid to see if that will help with the abdominal discomfort. For grade 2 colitis and above, we generally treat with steroid medications, such as prednisone or budesonide, also known as Euceris. Steroids are tapered down or decreased in dose according to the patient's response and symptoms. Sometimes, if the colitis becomes severe, patients need to be hospitalized for IV medications and for IV hydration. Here we have the Kidney Cancer Association website, which has a specific section for patients called Managing Side Effects, and is an excellent resource to find interventions specific to adverse events. So if we scroll down here we can see ways to manage diarrhea, such as avoiding spicy or greasy foods, avoiding dairy products, eating a brat diet or a bland diet, and the importance of adequate hydration. At minimum, patients should drink 2 liters of water per day. If you develop diarrhea while on immunotherapy, please call your oncologist prior to taking any antidiarrheal medication. If you have a fever of 100.4 Fahrenheit or greater, call your oncologist as well. Dermatitis, or inflammation of your skin, can present as a rash, itchiness, or sometimes vitiligo. To briefly touch on vitiligo, this is a loss of skin pigmentation that can occur with immunotherapy, but is rarely seen in kidney cancer patients. A rash can occur within the first few weeks of treatment. Here we see once again that combination immunotherapy has the highest prevalence of developing a rash at 72%. When we treat a rash, the first thing we need to address is if it is a local rash or a full body rash. For localized rash, meaning one specific area of your body, we would suggest a topical steroid such as over-the-counter hydrocortisone. If the rash causes itchiness, we recommend an oral antihistamine such as Benadryl. If the rash is everywhere on your body, this is called a generalized rash and requires oral prednisone. We would taper you off of the prednisone as your rash starts to improve. A referral to a dermatologist might also be made. Itching is a very common adverse event and is usually seen in patients on PD-1 immunotherapies such as nivolumab and pembrolizumab. The itchiness usually starts after the first 3 weeks of treatment and can be a localized or a full body itch. Of course, this can cause patients a significant amount of discomfort, and our initial treatment would be to start patients on Benadryl. Sarna cream, which is an anti-itch lotion for sensitive skin, has also been helpful for patients. Gabapentin or Neurontin and pregabalin or Lyrica can also be prescribed, but the response is very variable. A dermatology referral would also be placed if, despite these interventions, patients still had persistent itchiness. Here at the KCA website, it identifies things that patients can do to minimize skin rashes. For example, using mild, non-perfumed soaps, avoiding hot water when bathing, wearing sunscreen with at least SPF 15 and covering up when going outdoors, applying thick lotions or creams daily, such as Eucerin or Aquaphor, and avoiding scratching your skin to prevent skin breakdown. Here on the left, we see a 57-year-old female who was treated with combination ipilimumab and nivolumab, followed by maintenance nivolumab. She developed a generalized rash, which required steroids. On the right is an example of itchiness without the rash, a condition called prurigo nodularis, which causes hard, itchy lumps on the skin. Hepatitis is an inflammation of the liver and is usually found during routine blood work. It is most common with combination ipilimumab and nivolumab, with a prevalence of 13%. Single agent immunotherapies have about a 1 to 2.5% prevalence. There are two specific liver enzymes that we look for with hepatitis: the AST or aspartate aminotransferase and ALT or alanine aminotransferase. Bilirubin is another liver marker. To get an understanding of elevated liver enzymes, a normal AST is less than 37 units per liter, and a normal ALT is less than 55 units per liter. I've seen patients with AST and ALT levels in the 300s to 500s while on immunotherapy. They usually present with a very vague, non-specific feeling of fatigue. If there is a mild increase in liver enzymes, we assess if patients are on any new medications, such as antibiotics, have they been taking Tylenol, or whether they're consuming alcohol. We would probably continue to watch with repeat labs in a few days and follow the trend of the liver enzymes. For grade 2 hepatitis, we would, of course, stop treatment and start prednisone. By now, you might be noticing a common theme. Steroids are our drug of choice in managing immune-related adverse events. We would once again taper patients off prednisone as we see a response in their liver enzymes. When we talk about tapering steroids, keep in mind that this is not a quick process. Sometimes patients may need to be on steroids for at least 4 to 6 weeks. Some may need to be hospitalized. And in this case, patients may need to be hospitalized until their AST and ALT and bilirubin levels are within a safe level. Pneumonitis is an inflammation of the lungs that is not caused by an infection. This is different from pneumonia, where your lungs are inflamed due to a bacterial or viral infection. The overall incidence of pneumonitis is anywhere between 1 and 6% and is most often seen with PD-1 nivolumab. Your alveoli are tiny sacs at the bottom of your lungs that exchange oxygen. Pneumonitis causes inflammation of these sacs and decreases the alveoli's ability for oxygen exchange. This in turn causes shortness of breath, which is the most common symptom of pneumonitis. A dry cough is also very common. This picture is a chest x-ray from one of our patients who developed pneumonitis. There is an overall lung haziness or fuzziness seen in this image. Sometimes, patients may not experience any significant symptoms when they have mild to moderate pneumonitis, and it may just be diagnosed on a routine CT scan. The KCA website outlines management of pneumonitis, which would include a chest x-ray, a CT scan, and pulmonary function tests. We would start patients on prednisone. Most patients with pneumonitis are generally admitted to the hospital for oxygen requirements. I tell my patients, day one of immunotherapy is your baseline. You know what activities make you feel short of breath, how active you are. This should be your comparison from day one of starting immunotherapy. All right, endocrinopathies. Your endocrine system is made up of glands that regulate hormones in your body. Your thyroid gland can become inflamed from immunotherapy and can cause either hypothyroidism or hyperthyroidism. Symptoms of thyroid dysfunction can include extreme fatigue, unusual headaches, changes in weight, heat or cold intolerance. If you are experiencing any of these symptoms, please call your oncologist. Hypothyroidism is seen in about 22% of patients on combination ipilimumab and nivolumab, and between 6.9 to 14% with PD-1, PD-L1 immunotherapy. If patients have hypothyroidism, they will need to start levothyroxine or Synthroid. If patients are already on these medications, the dosing might need to be adjusted quite frequently. Hyperthyroidism is rare and many times does not require medical management. By doing specific labs such as TSH and T4, T3 levels, your oncology team can determine if your thyroid is functioning too much or too little. The adrenal glands produce steroids such as cortisol and a hormone called aldosterone, which helps to regulate your blood pressure, your energy levels, and response to stress. When these glands become inflamed, they decrease the production of these steroids, causing your body to go into shock. Patients can feel quite fatigued to the point of becoming lethargic, have a really low blood pressure, and severe electrolyte abnormalities. Adrenal insufficiency is a medical crisis that requires hospitalization and the need for lifelong steroids. If you experience any of these symptoms, once again, please call your oncologist. Now let's switch gears and talk about targeted therapies. TKIs, or tyrosine kinase inhibitors, work by blocking the action of tyrosine kinase enzymes. TKIs can stop or slow down the growth of cancer cells and stop the growth of blood vessels to the tumor itself. The TKIs we use in kidney cancer management are cabozantinib or Cabometyx, sunitinib or Sutent, axitinib or Inleta, lenvatinib or Lenvima, pazopanib, Votrient, bevacizumab, which is Avastin, and then there is another targeted therapy that specifically blocks the mTOR pathway, and that is everolimus or Afinitor. Fatigue is the most common adverse event from TKIs. In general, most patients will experience either mild to moderate fatigue. A patient's quality of life can be significantly impacted by fatigue and can interfere with their instrumental ADLs, such as going to work, managing finances, doing household chores, or their self-care ADLs, bathing, dressing, eating. Patients may have difficulty participating in social activities, have a lack of concentration, a decreased desire in doing the activities they once enjoyed. They may also experience sadness and depression. Here are some ways that patients can help manage fatigue. For example, prioritizing your activities to conserve energy, kind of doing things in a group, taking rest, and then doing another set of activities after. Allowing yourself to take naps during the day, limiting them to about an hour a day. Eating a well-balanced diet, trying to do some form of weight-bearing exercise, such as walking. Massage and acupuncture are a part of integrative medicine, and some patients have actually found it very helpful in managing fatigue. Now, sometimes, despite these interventions, patients continue to feel tired and they feel fatigued. It is important to remember that you do not have to feel this way while being on TKIs. We want you to have a good quality of life while taking these medications, and we don't want patients to stop doing really what they enjoy. One thing that your oncologist can sometimes do or might suggest is to go down on the dosing of your TKIs and see how you respond to a lower dose of the medication. Blood pressure management. So hypertension or high blood pressure is another common adverse event of all TKIs. Lenvatinib has a prevalence of 45 to 73%. Cabozantinib has a prevalence of 30 to 61%. Axitinib, pazopanib, sunitinib have a prevalence of 30 to 40%. Bevacizumab also can cause high blood pressure. If left untreated, high blood pressure can result in lasting damage to your organs, such as your heart and your kidneys. Managing your blood pressure is crucial for the continuation of TKI treatment. If patients are unable to control their blood pressure, treatment may be held or may be permanently discontinued. Blood pressure medications will need to be prescribed by either a patient's primary care doctor or oncologist, and patients must ensure that they take their blood pressure medications daily. Our goal blood pressure is to keep your top number less than 140 and your bottom number less than 90. Patients are instructed to take their blood pressure every day and write it in a log, which they should bring with them at their oncology appointment. If you have 2 consecutive blood pressure readings, which are greater than 140 over 90, you need to call your oncologist. If your top number is 160 or greater and your bottom number is 100 or greater, or you are experiencing symptoms of headache, blurry vision, call your oncologist immediately. Here are some tips on how to check your blood pressure at home. So when you wake up, check your blood pressure after you have used the bathroom. Don't drink any caffeine for about 30 minutes prior to taking the test. Sit quietly for about 5 minutes before you check your blood pressure, just trying to relax your mind. Place the blood pressure cuff directly on your skin and not over your clothes. If you have a high reading, take another 5-minute break and then recheck your numbers and see what they show. We recommend checking your blood pressure once a day while on TKIs, but patients should follow the guidelines of their primary care doctor or cardiologist if more frequent blood pressure checks are needed. Diarrhea can occur with all TKIs and is most commonly seen with axitinib and lenvatinib. We define diarrhea as 3 or more loose watery stools above your baseline within a 24-hour period. Like immunotherapy, we tend to treat grade 1 diarrhea with diet modifications, a BRAF diet, a bland diet, avoiding certain foods like spicy foods or greasy foods. For grade 2 and above, we would treat with antidiarrheals, such as Imodium. If Imodium is ineffective, we move on to other antidiarrheal medications, such as Lomotil and tincture of opium. Usually, Imodium is quite effective. Once again, if you do experience diarrhea while on TKIs, please call your oncologist prior to taking any antidiarrheal. If you develop a fever of 100.4 or greater, please call your oncologist. Hand-foot syndrome is the most common skin reaction with TKIs. It affects the palms of your hand and soles of your feet, causing a hyperkeratosis or thickening of the outer layer of your skin. Patients can develop painful blisters and calluses and can have redness and peeling of the skin. They may also experience numbness and tingling to their hands and feet. Hand-foot syndrome occurs where there are any pressure points or friction on your skin. For example, a patient who frequently types can develop hand-foot syndrome on their fingertips. Cabozantinib has the greatest prevalence of hand-foot syndrome at 42 to 50%. Sunitinib has a prevalence of 14 to 50%. Pazopanib has the least prevalence at 6 to 11%. In general, hand-foot syndrome is quite unpredictable with really no certain risk factors other than if you are using, your hands or your feet quite frequently with certain activities such as with your work. It is usually self-limiting and non-life-threatening. One thing to look out for is any signs of any infection. Because the skin may peel and break open, patients are at a greater risk of developing an infection. So look out for symptoms like, do you notice any redness on the palms of your hand or the bottom of your feet, any discharge coming out, any tenderness, any pain? If you do experience that, please call your oncologist. When you start any TKI, invest in a good moisturizing lotion, such as Aquaphor, Eucerin, or CeraVe. Urea cream is used if you have really dry, cracked skin. Moisturize your hands and feet daily, and remember to do skin checks. Do you notice anything abnormal? Are you experiencing any pain? For grade 2 hand-foot syndrome, oncologists prescribe topical steroids such as clobetasol, 0.05%. Lidocaine gels, creams, or patches can also be prescribed to help provide a numbing relief to the pain and discomfort. If hand-foot syndrome does not improve with these interventions, TKIs may need to be held for a few weeks and then resumed at a lower dose. So here are a few tips for patients to prevent hand-foot syndrome. One of them is to wear comfortable, proper fitting shoes. Sometimes patients have tried a cushion insole, cushion socks, and they find that helpful because it gives them some padding. I would recommend try to avoid walking barefoot. Soaking your hands and feet in Epsom salts and warm water can also be very soothing for patients. And then once again, just be mindful of the activities that you do, such as anything that can cause any increased pressure. If for patients who like to run, that pressure on the balls of their feet can sometimes irritate the skin and cause hand-foot syndrome. Sometimes gardening, holding tools, and holding your, grasping objects, that friction on your fingers can, potentiate hand-foot syndrome as well. Loss of appetite. So patients either lose the desire to eat or have taste bud changes, which affects the enjoyment of certain foods. Loss of appetite can lead to weight loss, muscle wasting, and dehydration. It is seen with all TKIs, but most commonly with cabozantinib and lenvatinib. I would highly recommend patients speak to their oncologist about a nutrition referral. Nutritionists are a very helpful resource because they can provide patients with meal plans and also find creative ways to come up with food substitutes. Some things that I tell my patients to help with the decreased appetite is try eating small, frequent meals as opposed to 3 big meals. Sometimes just schedule snacks so that you don't fall back on your, if you're really feeling like you're not eating or you don't want to eat or drink so much, just kind of have times where you feel that you could just take a small snack just to keep you going. Drink fluids with calories such as Boost or Ensure, and also maintain good mouth care, which we'll talk about in the next slide. Drink at least 2 liters of water a day. I know some patients don't really like to drink that much water. So I tell them, we find creative ways. You can dilute water in your juices. You can use powdered flavors. You can add fruit to your water to help with the taste. Patients can also take an over-the-counter antacid if they experience any indigestion. If patients are feeling nauseous, call your oncologist and they can prescribe you nausea medication. I would recommend taking it 30 to 40 minutes before your meal so that when you do start eating, you're not feeling nauseous and end up, having to bring everything up. All right. The final adverse event we will review is mouth care. Mucositis is an inflammation of the lining of your mouth, tongue, and lips. It can present as a mouth sensitivity or tenderness or lesions similar to canker sores. Mucositis is often seen in TKIs as well as another targeted medication, everolimus or Afinitor, which is an mTOR targeted medication. I recommend to my patients a baking soda saltwater mouth rinse as an effective way to keep mucositis well managed. I usually tell my patients to keep this rinse in their bathroom. Every time they use the bathroom, they wash their hands, they can go ahead and take that oral rinse and just swish it around your mouth and then spit it out. If patients develop mucositis despite doing the baking soda saltwater rinse, we do have an oral rinse that your oncologist can prescribe called dexamethasone. This rinse is made specifically by specialty pharmacies or compound pharmacies. So you may not be able to receive it at a local pharmacy, but talk to your oncologist about that. This rinse is usually kept in the fridge and its shelf life is about 3 weeks or so. But here is a great resource on things that patients can do just to help with mouth care. Using a non-alcohol toothpaste, mouthwash, using a soft bristle toothbrush, using chapstick for your lips and keeping your mouth moist. Biotine is a great over-the-counter oral rinse used for dry mouth, and patients, do really find that very helpful. If you do end up developing mucositis, just really avoid foods that can cause any irritation, such as caffeinated beverages, carbonated beverages. Avoid citrus fruits, oranges, lemons, limes, tomatoes. Avoid spicy foods. You may have to cut back on your salty foods as well. And then, of course, to avoid drinking alcohol. All right. So in conclusion, there are a number of adverse events that can occur with immunotherapy and targeted therapies. These adverse events are generally mild to moderate and can be treated with medication, but we need to remember that early intervention is key. Whenever you notice anything different from your baseline, however small you think it may be, call your oncologist. Don't think that you're bothering them, that you're calling them too much. We actually need to know how you're doing on these medications because we know the adverse events that can occur and the complications that can occur with them. Have an open communication with all members of your oncology team. Find out who do you contact if you do develop an adverse event. So find out who you should contact if you develop an adverse event. Also find out who you would reach out to after hours. Who do you call on a Saturday night when you have new onset diarrhea? Those are things that you should know before starting day one of any of the immunotherapy or the targeted therapy, because we know that these side effects can occur after the first cycle or within a few days of taking these medications. The other thing I tell my patients is to have a designated hospital that you would go to should you require any immediate attention. Does your oncologist have any affiliation to any hospitals in your area? Ask your oncology team. They may be able to guide you if they know of any local hospitals that they have access to their medical system. Also remember that you don't need to feel terrible while being on these medications and just think that this is, your new norm. I had a patient once who was on combination axitinib and pembrolizumab. He came into my clinic, into our clinic, for his second cycle of pembro. And when I went in to assess him, he very casually mentioned how tired he was, how fatigued he was feeling shaky, just not really feeling right, decreased appetite. I told him he should have called me sooner and we could have helped him feel better right away, as opposed to waiting 3 weeks until his next treatment cycle. And his response to me was, I thought this is the way I should be feeling. That statement resonated with me, and I can't stress enough that our goal is for you to continue to do the things that you enjoy doing while we are helping you to go through this process, with kidney cancer management, with getting you through these medications. We are here for you. The other thing I've seen is sometimes patients are afraid that if they call us with any adverse events, we will hold treatment and then their disease will worsen. Keep in mind that we need to give these medications safely because we know the complications that can occur. And we want you to continue with treatment so we can find ways to work around, adverse events. We kind of went through a list of things that we can have patients try to do at home. But just remember that your oncologist knows what is the best approach. If you ended up needing a treatment break, have that discussion with them. What would be my next step? What do you recommend I start taking? But keep that open discussion, but just call whenever you do have adverse events. Don't be afraid or don't be worried that, things will progress and then we kind of, just to keep your call your oncologist is what I'm trying to say. Also keep in mind that immunotherapies can have a long-lasting effect on your body. So that, sometimes patients can have adverse events after their first cycle, and then we may not necessarily restart treatment because we're just worried that these adverse events will come again. But just keep in mind that these immunotherapies don't really come out of your system. They can be in there for a while, and we know that because patients can have adverse events from immunotherapy even after they're discontinued. So just keep that in mind as well. Sometimes with targeted therapies, your dose may need to be reduced. Even if you do have a dose reduction, just you're not losing out on the clinical benefit. We would rather have you on a lower dose for a longer period of time, as opposed to a higher dose where you experience, really, unpleasant adverse events, and then we may just have to discontinue treatment altogether. I think in the end, the most important thing to remember, if you take anything from this presentation, is anything that is different from your baseline, any questions, any concerns, please call your oncology team. They will help guide you through this. You are not alone on this. Let us know how you're doing, because we want to make sure that you are taking these medications okay, and that you're still able to do the things that you enjoy doing. Thank you for participating in this presentation. I look forward to any questions you may have. Thank you. Bye.
Great video. Thank you very much, Karen.
Thank you. I wanted to thank everyone at the KCA for letting me be a part of this. And before I go over, or we talk about the Q&A and go over some questions, there are just a few other side effects that I wanted to discuss, just because I've seen them in our clinic practice recently, and I definitely think they're worth mentioning. So one of the side effects that can occur from immunotherapies are neuromuscular symptoms. Neuromuscular symptoms are, inflammation of your nerves and inflammation of your muscles. So symptoms that patients present with are numbness and tingling, to their legs, to their arms. It may kind of start at one part of your body and then progressively make it, work its way up. Some patients are, notice that they are not walking as steady as they did before, or they have an imbalance when they're walking. They may develop, foot drop, or not being able to kind of lift your foot up as you
It seems we're having a little bit of technical difficulty right now. If you could all just stay tuned, stay with us. We will have Karen back on with us. Just as a note, please, we will be taking questions, so please feel free at the bottom, I believe left of your screen, our question box. So go ahead and get started, and we'll be happy to take those questions. We hope that you've been enjoying the day today with us for the virtual patient symposium. For those of you that joined us at start, I'm Rosemary, I'm your patient liaison. Feel free to connect with me anytime you might have a question or need help navigating, or need some services, or if you want to learn a little bit more about the Kidney Cancer Association programs and services that you offer for you, or that we offer for you. please reach out to me. You can call me at 800-544-3522, and that's my line directly. Okay, and I just have a note now. Karen is dialing in. She will be with us just shortly. I do apologize about the delay, but we will be back on track in a moment. So thank you for your patience. And per chance, does anybody have any questions for me? Wow.
I did that. Can you hear me? Okay, perfect. You can hear me okay? Okay, great. Sorry about that, technical difficulties. But
I welcome.
Where did I leave off? I was talking about neuromuscular symptoms. So one of the other side effects from immunotherapy is developing myositis or muscle weakness. So this could just be generalized muscle weakness that patients experience. And the reason why I bring this up is because, sometimes patients mention that they just feel fatigued and they kind of expect this from the treatment or expect this from their disease. But, there also may always be an underlying issue or a reason for feeling fatigued and weak. And, it's important to let your oncologist know if they need to do any further workup to determine where the weakness is coming from. And then in terms of other neurological issues that can occur, patients may develop vision changes or they may have difficulty swallowing. So those are things that you need to let your oncologist know of. Speaking specifically of vision changes, I never want to, I do want to mention that if you have any vision changes, double vision, blurry vision, that actually, you need to be evaluated right away for that. So definitely get evaluated, for other complications that may occur as well. And then the other side effect I wanted to discuss real quick is specifically with TKIs, in that they impair wound healing. So if you have any open wounds, let your oncologist take a look at them and evaluate them before they start you or continue you on these medications, because those wounds, can quite quickly get worse while being on the TKI regimen. So definitely let them be aware of that. If patients have any invasive procedures that they're scheduled for, or any invasive dental work, let your oncologist know. And in general, we would hold the TKI for the treatment, and the time frame we would hold it would be, dependent on how quickly your wounds are healing, and kind of how you're doing, if there's any risk or concern for infection. And then lastly, I do just kind of want to make a statement that, these medications can always cause, complications, which may include chest pain or having difficulty breathing. And I just want to put that out there, that if you do experience any of those symptoms, just go to your local ER, be evaluated, and then your oncology team would always be kind of looped in on anything that was done. But just to kind of be aware that if you have those symptoms, you need to be seen right away. And that's what I wanted to add. So.
Thank you. We do have some questions for you, Karen, some more questions. So we have somebody's asking, Pembro and Axi combo, new patient. Do you have a top 5 list of home remedies or items we should have on hand?
So Axi Pembro, one thing that I've seen with immunotherapies is that they, may cause rashes. They may cause itchy skin. If you do have any of those symptoms, for the rashes, you can purchase like a topical steroid over the counter and apply that. But of course, if you have any of these, definitely let your oncologist know. But that's something I would recommend. I would
always recommend a good lotion, especially with TKIs. The hand-foot syndrome I've seen with patients can sometimes be pretty bothersome. And I think just having a really kind of thick-based cream, to put on your hands, your feet, and be really diligent about it, especially I think in the winter months with dry skin, that's something I would recommend as well. Patients may develop mouth sores. So one thing that patients, I recommend is just a baking soda, saltwater rinse to start doing when you start treatment. Just regular table salt, regular baking soda. And those rinses actually do kind of go a long way. It's such a simple home remedy, but patients say, I had a sore, I did the rinses, and, they resolved. I would invest in a blood pressure cuff, absolutely. When you're on TKIs, you must check your blood pressure every day because the risks of developing hypertension or high blood pressure are quite significant. And if you end up, having high blood pressure, we don't want to hold treatment if we don't have to. If it's something that's manageable. So definitely invest in a good blood pressure. And I went over the steps on how to take your blood pressures, kind of accordingly. So that's another thing I would suggest. And I think what I would recommend your oncologist when they do start you on a treatment regimen is just kind of prescribe you a nausea medication. Just kind of right away that if you do feel nauseous, you have it on hand as opposed to waiting for a prescription, waiting for the oncologist to get back to you. So just kind of keep that on hand with you that if you do end up feeling nauseous, you can take something right away. And hopefully that provides you some relief. I think that's what I can think of off the top of my head. But that's a really good question for me.
All right, thank you. So we have another question. Someone is asking, is there anyone who struggles with eating enough calories, and what do you do?
So I've seen this actually, and there's a few things I tell patients. I think the idea of kind of 3 big meals, it may not work for some patients, kind of having a few small meals throughout the day, may help instead of a big meal all at once. Kind of setting times for yourself where, it's 10 o'clock right now, I'm not really feeling hungry, but, I'm just going to have this yogurt, or I'm just going to have these crackers just to kind of keep me going. The other thing I really strongly recommend, and I find so helpful, are speaking to a nutritionist. So letting your oncology team know that, I'm not really eating much. I'm trying all these different things. What should I do? And speaking to a nutritionist, they can come up with meal plans. They have, kind of various, all these creative ways that they can help you build up your calories, build up your protein, and kind of really work along with you and what your specific diet is, because we all don't have the same diet. So I think that's important to work, with what you are kind of accustomed to eating. And I really think, boost and ensure. I know some patients don't like that, but I do think that is one way to just kind of keep your caloric intake up. They come in different flavors. You can put ice in it to, see if that helps with the taste. But that's another thing I would recommend.
Very good. And thank you for the question, audience. We have another. Does having side effects mean that my treatment isn't working, or that I'm just not going to have better outcomes?
That's a really good question. So I would say that side effects are not a predictor of treatment outcomes, in the sense that we know that these side effects can occur based on the data and the percentages of what, kind of the most common side effects are based on their grade. I think the idea behind side effects and managing them is that we don't want to have these side effects go from a grade 2 to a grade 4, where we've kind of reached a point where if we give you more treatment, we're kind of doing more harm than good. So I think that's what's important. And I think we have to remember that if you are having side effects, it's not necessarily that the treatment isn't working. It's just that we know that these medications can cause this, and it's something that we have to manage. And I think the idea is we would rather, have you on maybe a lower dose of it for a longer period of time, as opposed to giving you a high dose and, you not being able to tolerate it. With immunotherapy specifically, the side effects, it's hard to say if it's a predictive marker of if they're working or not. Immunotherapies are so kind of a new treatment that has come out. So that I wouldn't be able to answer, and I would probably have your oncologist discuss that. But in general, the side effects are not really an indicator of, how, if your disease is progressing.
Okay. Thank you very much. Can I have another question? Can I have side effects so bad that I have to stop treatment, like totally?
So in general, that can happen sometimes. Just trying to think of an example. So for example, if a patient is on immunotherapy, one of the common side effects from immunotherapy is, not common, but one of the common side effects that can occur is colitis or inflammation of your colon or diarrhea. We try to kind of assess and treat at the onset of it, but sometimes if we kind of catch it a little bit later, patients can develop pretty severe colitis where we may no longer be able to give immunotherapy because of risks versus benefits. That's something that we have to evaluate. And if we give you more treatment, we'll probably end up kind of recharging or kind of stimulating the colitis, and that could lead to further complications. So that is possible, yes. But I think, once again, that's a great question because it emphasizes the point of calling your oncologist, kind of at the onset of any symptoms, as opposed to waiting, because you're right, sometimes we may have to stop treatment.
Very good, thank you. And side effects, another question I have for you. We got lots of questions for you today. We're very glad you're here. So side effects after I stop treatment, can side effects be permanent for years after or come back or reoccur later?
So another great question. I would say that, so with immunotherapies, we don't know kind of how long they could stay in our system. So for patients who develop side effects such as hypothyroidism, they may need to now permanently be on, Synthroid or, an oral medication to help manage the hypothyroidism, or they may need to be on, hydrocortisone is another medication if they have adrenal insufficiency. So this may need to be something that they're on continuously. Side effects with immunotherapy can also occur, 6 months or sometimes even a year down the road. So those are things that, we are kind of, we pay attention to. And if we notice, that if they're having any immune side effects, it could be from that. In terms of TKI side effects, I would say that the thought process is that if the TKI medications, we kind of, follow their half-life of the medication. And we would expect that once we reach that half-life, that the symptoms or the side effects associated with that medication would decrease or, kind of eventually normalize. So that's what we would expect from TKIs. And, some of these side effects, once you stop the medication, you may feel better in a few days, or you may feel better, 10 days from now. It just depends on how long that drug is in your body. But TKIs, we would expect you to feel better. With immunotherapy, it may be longer lasting.
Okay. Thank you.
All right. Any more questions, Rosemary? Is that it?
That was the last question. Thank you.
All right. Well, thank you, Karen. Thank you so much. And on behalf of the Kidney Cancer Association, I want to thank everyone who took time out of their day to join us. We're really excited. This is our first annual, so we will do another symposium in 2021. We sincerely hope that you learned something today, whether you're a patient or caregiver or family member. Hopefully you found something worthwhile in today's presentation. Just so you know, all of these sessions have been recorded and they'll be available on the KCA website within the next 4 to 6 weeks. If you haven't had an opportunity to watch the videos that were pre-recorded, there's a couple of sessions that are currently on the KCA website. So if you're dying for more content, you can certainly watch those on the website. Those will be there, and then we'll upload those other ones as soon as they're ready. So we'll have some really great recordings and tools for patients to learn. The KCA team is always available to answer your questions. You can certainly reach out to Rosemary directly through the Patient Navigator program. You can reach her at patients@kidneycancer.org or call 1-800-544-3KCA. And that's it. Enjoy the rest of your weekend. Thank you guys so much again for attending. Bye.